the last Puscast for 2020, the first podcast for 2021. I suspect that we will look back on 2020 as one of the good old days, so good luck moving forward. This Puscast will cover the infectious disease literature for the last 2 weeks of December in the year 2020. References, as always, are available at edgydoc.com, the home of my multimedia empire. So let's move on to the literature, shall we? As is the new normal, we'll start with a series of COVID articles. There is, by the way, this month a review on the treatment of COVID in the New England Journal of Medicine. I commend it to your reading. Now on to some articles. The first concerns how soon you get neutralizing antibodies with severe COVID. And the answer would be, quote, seropositivity rate reached 100% within 20 days of onset and lasted at least a couple of months. I think it's very clear when you look at all these antibody response articles that everybody is seropositive by day 20, and I would presume at that point non-infectious. A description of the notorious outbreak on the aircraft carrier that led to widespread COVID-45 on said aircraft carrier. The important thing is that 50% of those who tested positive had no symptoms. So we keep going back to the importance of asymptomatic patients as sources of COVID-45. It's hard to organize these, so I do jump around a little bit. This article looked at how rapidly the antibody response waned in patients with both asymptomatic and symptomatic COVID-45. And they found that the mean titer fell by roughly half, well, maybe a third, 219 to 143 at 5 months. Although when you look at the graphs, they were all over the place with antibody titers. So in some patients, certainly antibody titers do fall over time. Whether or not that translates into susceptibility to infection is unknown, but not unknowable. Interestingly, they tested over 12,000 healthcare workers in a short period of time, April through June, in the San Francisco area, and found that less than 1% of healthcare workers were positive for COVID. However, this was before the current explosion of COVID in California. But I think these studies do suggest that the PPE we are using really does work pretty well most of the time. Combine that with a vaccination, which evidently many healthcare workers are refusing, and you should have excellent protection from COVID-45. And although Mad King Donald says that the death rates are overestimated, it's probably more likely that they're underestimated. And when they look at excess deaths in populations, they found them to be a little higher than the number of patients who actually died of COVID. So, for example, in March through August in California, they had roughly 19,800 excess deaths, somewhat more, as I read the graphs, than is reported from COVID. And there are information that the actual number of cases is anywhere between 4 and 10 times what we suspect based on testing. For example, in Chelsea, Massachusetts, where they had a ton of COVID, half of people are seropositive, of whom, no surprise, 50% were asymptomatic. So when you read the reports of deaths and disease in the United States, it's way worse than we think it is. I've always been a fan of Faget's sign, pulse temperature dissociation, and there have been several articles to show that Faget's sign is part of COVID-45. This article, however, out of Singapore, suggests that not only do you see Faget's sign in patients with COVID-45, but they also saw it in influenza. Influenza has never been on my list of diseases that cause Faget's, my list consisting of typhoid fever, brucellosis, yellow fever, Legionella, and chlamydia, at least before the COVID epidemic. And I'll have to keep an eye out on influenza if we ever see it again. There doesn't seem to be much currently due to masking. And see if there really is pulse temperature dissociation for influenza. And an interesting study out of Seattle looked at the seroprevalence of COVID-45 but in symptomatic healthcare workers, and they found that the rates were identical in frontline and non-frontline workers, around 5% in this study. Of course, Seattle had their storm of COVID-45 before San Francisco did. But again, my take home from this particular study is that frontline workers should have higher rates of COVID unless PPE was working, and also suggests that those who came down with COVID may have been acquiring it from the community once they went home and doffed, I've always hated the word doffed their PPE and took off for the day. Although I still suspect that the dangerous areas in the hospital or the cafeterias, sorry about that, I'm getting so used to using dragon dictation, I automatically start dictating punctuation. But it's the break rooms, the cafeteria, and I suspect it's the bathrooms that are dangerous. So people go into the bathroom and they take their mask off while they relieve themselves, and then the next person coming in takes their mask off, does the same, and inhale the COVID in the bathroom. So I only eat and relieve myself outside now. Only half of that is a joke. An outbreak of COVID-45 in a Marine Corps camp. Most of the outbreak spread within platoons. Most patients, of course, did not have symptoms for their COVID. But I think the important outcome from this particular study was, quote, no infections were detected through daily symptom monitoring, end quote. I still suspect that this kind of screening we do with temperatures and asking about symptoms is mostly medical theater that has no actual infection control benefit. Although I should ask if we've actually caught anybody who was trying to sneak into the hospital when they were symptomatic for COVID-45. Another seropositivity study, this one comparing a variety of serologic tests in patients with both symptomatic and mildly symptomatic COVID to see how long they maintained their antibodies. This one actually went out 8 months, and in all the different assays, the seropositivity was up to 90%, depending on the assay that was used. Interestingly, for neutralizing antibody, females tended to have a much better antibody response than males. And there seems to be a great variability in antibody response, depending on whether patients shed or not, what their gender was, etc. So one of these days, we're going to need a nice review of all this to put all this data into one nice bucket to understand what is the antibody response to COVID-45 in whom and for how long. Mostly, though, it's looking good if you're female and not quite as good if you're male. There are many infectious diseases that result in a post-infectious fatigue state, not limited to Lyme, Rift Valley fever, Q fever, Epstein-Barr, and now COVID-45. And Open Inform Infectious Diseases has a nice review of the post-COVID syndrome that currently plagues a fair number of patients. Given the ubiquity of the receptor in the human body and in important organs for COVID-45, I'm not surprised it may cause some long-term damage in some people. And I will be very surprised if we find something to do for it. Yet another reason I'm glad I got the vaccine. Now, the problem with the PCR is that it finds DNA, not active virus. And we often get positive tests in patients long after they should no longer be infectious. I figure it's like finding Neanderthal DNA. Just because you locate some DNA doesn't mean they're going to be joining you for dinner that night. Now, when you do a PCR for patients in COVID, they have to run multiple cycles sometimes of the PCR assay before there's enough DNA to detect the so-called cycle threshold. Interestingly, they looked at patients who had a positive PCR and they looked at the number of cycle thresholds before they were detected. And they only found infectious COVID in vero cells in patients who were symptomatic for less than 8 days or who had a cycle time threshold of less than 24. Again, suggesting that anybody who has a positive PCR after day 8 is likely no longer infectious, and all you are doing is picking up random bits of genetic material. It would be interesting if they routinely reported the cycle thresholds on PCRs, as I like those curious bits of information, and it may help you when you get one of those late positive PCR tests that are positive, he says very redundantly. Another review on Aspergillus and COVID. I have been mostly plagued by Aspergillus as the big, late, opportunistic infection in COVID patients, and my outcomes have been grim so far. I used to say that in the azole era, I haven't had a death due to Aspergillus. I don't think that's the case with COVID. And finally, viral load is associated with mortality, although I don't know what you would do with the information because it's not like you can impact COVID-45. So I've never been a big fan of all these prognostic studies because they don't really help you with the day-to-day management of patients. And that brings us to the end of the COVID part of our Puscast here. There are other infectious diseases besides COVID-45, and now we shall move on to them. Just to remind you that when applied to populations, neuraminidase inhibitors are effective in treating the flu. This meta-analysis found that it was associated with reducing time to clinical resolution, decreasing influenza-related complications, including otitis media, decreasing antibiotic use, and reductions in, quote, mortality, pneumonia, bronchiolitis, asthma, and hospitalization, with the big side effect being that of nausea and vomiting. So I know it's popular for people to poo-poo the effectiveness of drugs like oseltamivir, but especially when applied to populations of people, they are of great benefit and fairly minor side effects. And I would argue that nausea and vomiting is reversible. Death, not so much. People, I think, underestimate the mortality and morbidity that occurs when people can't afford health care. This study looked at the results of viral loads in patients who were able to get on the Affordable Care Act. And once they got on a insurance plan, they stayed on it, and they tended to have a decrease in their viral load that persisted, in part because they could afford their medications now. So it is a benefit in HIV patients and everybody to have affordable care that allows them to get health care. Also, in the same study, fire is hot, water is wet. The motto should be HPV. It's not just for females anymore. The study looked at vaccine effectiveness to prevent anal and oral HPV in men who have sex with men, and they found that it was beneficial, and that the sooner you got it, or I should say the earlier age you got it, the more effective the vaccine was. In other words, you really want to get vaccinated before you become sexually active. That's true of females as well as males. And one would presume if they do not have anal or oral HPV, they won't go on to get cancer in those areas as well, which is a good thing. Boca viruses usually cause diseases in children, mild pneumonias, and it has been associated with acute exacerbation of COPD. This is a report out of Korea of a patient who developed a severe human Boca virus infection. It's in the Parvoviridae family. Subsequently diagnosed several cases. They gave rates of pneumonia as about 0.5%, and patients who developed pneumonia often had underlying lung disease or some sort of hematologic malignancy. And death rates varied from 50 to 80% depending on the patient population. And this represents the first series of severe pneumonia secondary to human Boca virus. So add it to your list of potential causes of viral pneumonia. For years, the recommendation for the treatment of gonorrhea was a single shot of 250 milligrams IM of ceftriaxone. And they've increased that dose now to 500 milligrams single dose of ceftriaxone because the MIC is creeping up to ceftriaxone, which is what we continue to do. A little bit of antibiotic is the perfect way to develop resistance. I don't know. I've never been a fan of a low dose of antibiotic for the treatment of anything is that's how resistance evolves. You give it a chance to survive. It strikes me that increasing the recommendation from 250 to 500 is just ushering that process along quite nicely, where one day we'll have a pan-resistant gonorrhea. I still think for most infections you should give the maximal dose for the least amount of time possible. There was a fairly depressing article on the frequency with which police are clients of sex workers in Baltimore City, and that they frequently used coerced or forced sex by the police, and it subsequently leads to sexually transmitted diseases in those populations. So those gritty movies of policemen taking advantage of streetwalkers are based on Baltimore City reality. I wonder if the spouses are aware of this. It's quite a depressing study. So, what to do with sero-fast HIV-negative syphilis patients? Because some of them might have asymptomatic neurosyphilis. And who would that be? Well, in this population, it was 27% of patients had asymptomatic neurosyphilis, and the risk factors were having less than a 4-fold decrease in their RPR and an RPR greater of 1 to 32. So if you treat someone with syphilis and their titer doesn't fall 4-fold and it stays above 1 to 32, you got to consider asymptomatic neurosyphilis, especially in Baltimore City policemen. And as long as we are on the topic of spirochetes, there was a review of normal pressure hydrocephalus out of Europe, which is a different kind of Lyme disease, in patients with Lyme disease, and a review of the 7 other reported cases in the medical literature. 8 cases is association, not causation, but it's something to consider. I'm not sure I would necessarily send off Lyme serology in someone with normal pressure hydrocephalus, especially in the United States, but perhaps if they were a Swiss hiker, for example, since it appears that European Borrelia are more neurotoxic / invasive than the U.S. strains. I always dread a page from the 5th floor because that's the OBGYN delivery floor, and I always get the willies when I have to deal with an infected pregnant woman. This study actually looked at what are the causes of fevers in women who are pregnant, and it turns out that it's mostly mundane stuff. The majority had a viral infection, usually flu. Then they had bacterial infections in about 1/5, usually pyelonephritis or pneumonia, and then a smattering had torch infections. So it would appear that the usual cause of fevers in pregnant women are mundane stuff and not exotic infections for which they need an infectious disease consultation. And a reminder that Ehrlichia is increasing, this at least per a report from the CDC covering the years 2012 through 2016, where the rates have been going up, especially in the Southeast, the Midwest, and parts of the East Coast, with Missouri leading the list for causes of ehrlichiosis. As the vectors move with global warming, I have no doubt that the incidence and range of Ehrlichia is going to change, along with all other tick-borne diseases. How best to treat group A beta-hemolytic strep infections? It's a beta-lactam plus clindamycin. In large part, the clindamycin is used for the eagle effect, where streptococci are resistant to beta-lactams at high inocula. And there are multiple studies, predominantly in children, to show that clindamycin leads to better outcome. This is a study in adults that also showed that patients with invasive group A strep infections did better with a beta-lactam and clindamycin, even if they did not have a necrotizing fasciitis or shock. And then a similar study, kind of sorta, asked the question, well, what happens if you have clindamycin resistance, which occurs in about 1/3 of patients with group A strep, and they do worse. And in this study, it was associated with an increased risk of amputation if you had clindamycin resistance. The problem is it takes 2 or 3 days to get your clinda resistance back, One would wonder, one of course being me, if these patients would benefit from linezolid. And a quick search does show that at least in an in vitro model, you get the same effect of linezolid with penicillin as you do with clindamycin with penicillin. So you got to wonder with 30% resistance if group A strep, if pending susceptibilities, you shouldn't have the patient on linezolid instead of clindamycin, or to make your pharmacist seize both clindamycin and linezolid until you get your susceptibilities back. That, of course, is being combined with the beta-lactam. And that seems awful excessive, but you never know what to do until you get your susceptibilities back, and if it's clinda resistant, you're a little too late. Yet another clinical trial that needs to be done. As long as we're on the topic of lower extremity infections, this is an interesting study where they looked at the outcomes of diabetic feet infections, specifically osteomyelitis, who've undergone debridement, and it was prospective and it was randomized, and patients either got 3 weeks of antibiotics or 6 weeks of antibiotics, and guess what? The outcomes were the same. I will admit this was an interesting and difficult study to glean because I wasn't sure from their definitions if some of these infections were considered surgically cured or not. They did have patients with leftover bone that may or may not have been infected, but I can't tell if in these surgical debridements all the infected bone was removed definitively. Quote, we determined if there was persisting bone infection in the case of partial amputation by pre-surgical radiological and or intraoperative assessments, end of quote. And I usually use the histopathology of the bone and whether or not the margins are clean. They are of the opinion that it is more common to wrongly assume a clean amputation than to remove all infected tissue during surgery. I don't know if that's true at my institutions. My approach is if the podiatrists tell me they got it all, I don't treat more than 3 days. And if they tell me they didn't, I give them a longer course of antibiotics. But given the vagaries of diabetic osteomyelitis, I'm not really quite certain how to interpret this particular study in the context of my own practice. As you could argue that if they had sufficient debridement with amputation, they were cured and didn't even need the 3 weeks. I may have talked about this study before. I may have, as it came out in October, but I can't find it in my files. It asked the question, do you have to go with a quinolone when you do your step down for bacteremic E. coli UTIs? And the answer is no. They found that oral beta-lactams were just as safe as quinolones for patients with E. coli bacteremia, which does not surprise me. I still remain of the opinion that the bacteremia probably doesn't matter after the first 24 hours. For the vast majority of infections, the bloodstream is rapidly cleared, and the big question is, what's your source and how well have you controlled it? With the two big exceptions being staph and candida. But beta-lactams are often less expensive, like amoxicillin, and certainly without all the downsides of quinolones. So I always think if you can give a beta-lactam, give a beta-lactam. I still think there's no finer antibiotic. Another study to show that there is limited utility in doing repeat blood cultures. And this study looks specifically at streptococcal bacteremia. And they found that once patients were on appropriate antibiotics, they didn't often have repeat positive blood cultures. For streptococcal infections, you don't need to document clearing of the bloodstream, and you almost never do anything with the result anyway, so why waste the money? They suggest that the people who should get follow-up blood cultures are perhaps those at risk for deep-seated infection and those with endocarditis. And I don't really see the utility in either recommendation. If you know they have strep endocarditis, getting repeat blood cultures doesn't tell you much. And I don't know who's at risk for deep-seated streptococcal infections. Usually it's pretty obvious when they have them. So my take is that I virtually never repeat blood cultures in patients with strep in their blood or the Enterobacteriaceae if they're on appropriate antibiotics. 99% of the time, it's a waste of money. And it's the patient's money you're spending. And if you were wondering if your coagulase negative staph is MEC A negative, it has a 100% rate of being susceptible to oxacillin. So it's as useful for coag negative as it is for coagulase positive staph, and gives you a tool for rapidly getting the patient off the vancomycin if they have one or the other in the blood. I don't know if you remember the brouhaha about treating sepsis with hydrocortisone, ascorbic acid, and thiamine, and there was a single report that when it came to mortality, it was the wonder drug combination that worked wonders. Subsequent studies have not confirmed that observation, but this particular study did show that once it was released, use of all of these therapies went up, but it did not have an associated mortality benefit. So I think hydrocortisone, vitamin C, and thiamine now belong to the dustbin of history. What a surprise. A report where they went back and looked at antibiotic susceptibilities over a 7-year period for nocardia. And they found, as in previous reports, that antibiotic susceptibilities was widely variable between different species. So if you get a nocardia, you really need to send it off for exact speciation and susceptibilities. But the 3 antibiotics that remained susceptible to all of the above were TMP sulfa, amikacin, and linezolid. And there have been a bunch of case reports of late showing linezolid to be an effective drug in the treatment of nocardia as well. So if you're waiting for your susceptibilities to come back, Bactrim, linezolid, amikacin. Those are your nocardia drugs while you await the results. I remember back in the day there was reports of isolated aspergillus brain abscesses in heroin users. Now you can add mucormycosis to the list of isolated fungal abscesses in injection drug users who are otherwise immunoincompetent. The infection, interestingly, had a predilection for the basal ganglia in at least 85% of patients. And, quote, no patient survived without amphotericin, and steroid administration was associated with worse outcomes. Although, interestingly, it would look that the therapies were usually amphotericin versus no therapy, and that very few patients received the modern azoles like posaconazole and isuvaconazole. And it also depends on which subspecies of mucor, I suppose, was causing the disease, what the best antibiotic would be, since rhizopus, rhizomucor, mucor, and Ibsidia are all different fungi that cause the syndrome of mucormycosis. But like aspergillus, I tend to say that in the pre-azole era, the pre-posaconazole era, I never had a mucor survive, and I haven't had one die since. That's not 100% true, of course, but you get my drift. But here's hoping I never have to put that to the test in a mucor cerebral abscess in a shooter in my remaining 3 years or so of practice. Yeah, I made the mistake of marrying a younger woman. My wife just turned 61. She's a year and a half behind me, and right now I'm working for health care. So December 25th, 2024, she becomes Medicare eligible, and I'm out of here. So there may be an ID job opening sometime after December 25th, 2024. But who's counting? It's always debated whether or not blastocystis is actually a cause of human disease or it's just part of the normal bowel flora. There is now a pair of challenge cases, inadvertent, that shows that blastocystis does nothing. 2 patients who got a fecal transplant accidentally got blastocystis as part of their transplantation, and neither patient got sick. So if you're a Koch's postulate kind of guy, that would be very strong evidence that blastocystis is not a pathogen. As the article says, quote, the presumed enteropathogenicity is based on anecdotal case reports and retrospective reviews and in mainly tested in animal models. So these 2 reports kind of swing the arrow towards not a pathogen. Amoebas are coming your way. The study looked at the geographic range of amoebic meningoencephalitis, and they find that it's moving north. In cases of Naegleria, are going where the warm water is. Go north, young man. I remember that case of a kid way up in the Midwest who came down with Naegleria and had never left the Minnesota area. And it's reached the Pennsylvania border as well. one of many infections, as I've already talked about, that are moving up north with global warming. Here in the Great Pacific Northwest, we're likely to be protected because all our forests will burn and boil the water sterile. Yay! I look forward to another smoky hellscape this summer. Although about 5 years ago, there was a winery that had this wonderful smoky wine thanks to the fires, and I haven't seen that repeated yet. So there's good things to come from massive conflagrations. And another reminder that schistosomiasis is now endemic in the island of Corsica. A case report of a German who went to Corsica and developed schistosomiasis later. It appears to be a unique meld of hematobium and bovis, a hybrid that is now in the island of Corsica. On the topic of MDROs, this study found an acquisition rate of 38% in U.S. international travels. I've always said that humans are basically sentient transport media for MDRO, and this is another study that shows that they use our rectum as a way to get around the world. We don't have a lot of MDRO/CREs here in the Great Pacific Northwest, so I'm about to mispronounce this antibiotic. But there are two separate reports out to suggest that when it comes to Enterobacters, you should not rely upon cefiderocol, if I pronounce that correctly. One was an Enterobacter that was exposed to cefepime and developed resistance to both ceftazidime avibactam and cefiderocol. The other was in the Credible CR study, which looked at the effect of cefiderocol in various organisms with carbapenem resistance and found increased death rates in those with Acinetobacter infections. So be leery of that agent for Enterobacters and Acinetobacters. And finally, it's always a popular pastime to try and guess what historical figures suffered from. You may remember Hannibal, who was famous for crossing the Alps with an elephant and getting a mountain with a memory, but it also allowed him to defeat the Romans. I did not know this, but he got a severe eye infection that led to vision loss in one eye. And this article suggests that it may have been an elephant-associated zoonosis, and they point to either Pseudomonas species or Acanthamoeba species as the best microbiologic explanation for his keratitis and subsequent blindness. And they think this is a better explanation than elephant zoonoses, where people have credited leptospirosis, Mycobacterium tuberculosis, and M. bovis, and brucellosis as elephant causes of his visual loss. But they think he probably got the Pseudomonas or the Acanthamoeba from the Florentine floodplains as part of his invasion. We will never know, of course, but it's always entertaining to hypothesize what infection killed people in the past. Years ago, there was a case presentation at Grand Rounds of an interesting case, and the audience was asked to participate into the differential diagnosis, and all sorts of illnesses were hypothesized to account for the patient's interesting collection of symptoms. And then towards the end, it was revealed that it was Alexander the Great he was presenting. I forget what we decided at conference was the cause of his death, although others have suggested amoebiasis. And that brings this Puscast to a close, a review of the infectious disease literature covering articles I found of interest that were published between December 15th and December 31st in the year 2020. Otherwise, references are available at edgydoc.com, the home of my multimedia empire. Happy New Year. I hope 2021 is a good one for you. And as I said before, I still suspect that we'll look back on 2020 as the good old days. And take it away, Jeff.